It's a lot of shit to remember, so.
Yeah. But you guys have to learn how to do it. So for me, it's one thing if someone comes in with shoulder pain and I do a focused shoulder exam and probably include the neck. It's another to go ahead and do TMJ, C-spine, shoulder, elbow, wrist, hand, and go through all of that on one patient. So I've had to relearn this as well. All right, so as you guys know, with most of your HAPE checkoff type stuff, you want to come in and make sure that the patient's disrobed so that you can get to the areas you need to get to. You don't need to shed your shirt for this now. You can do that later if you want. And then I'm going to go ahead and just kind of walk you through this exam. So I know you guys would, of course, wash your hands, introduce yourself, explain what a PA is, all that stuff. I might as well wash my hands just to be before I put my hands on your face. All right. So if we start the exam, and if we start with TMJ, always starting with inspection, whether or not you guys need to verbalize this or not for checkoffs.
Checkoffs they do.
Okay.
And it's easier if you're letting your partner know so they get to review and you're making sure that whoever's telling you the exam in the lab knows that you know what you're doing.
And for the sake of your checkoffs and the way that they're organized, yours typically start with range of motion type stuff and then go to palpation. I may allow that between the range of motion. So active range of motion, I just want you to go ahead and do what I'm doing.
There's a lot of things to remember, so I'm just going to do it.
Okay, close them up, side to side. Stick your chin out at it. Good. You're going to palpate the tragus. Okay. And go ahead and open up your mouth real wide again. Okay, go ahead and shift your jaw side to side. A lot of times when you do that there, you might appreciate some crepitus if they're having any TMJ problems. Okay, TMJ exam's easy. That's it, okay? Active motion, a lot of times I'll have a patient just imitate my mouth.
I have that too.
Keep your chin down to your chest. Just go ahead and look up at the ceiling. Come back to normal. Bend to the side. Bend to the side. Back to normal. Rotate to the side. Rotate to the side. I know this is the hard part being in front of the class right now. Okay. So that's basically flexion, extension, side bending, rotation. We did all the motions right there. We'll do the resistive motion. I'm just going to rest my hand on the side of your face and let you turn your head against it. Good. Same thing the other way. Okay, good. So we've done resistive rotation. And then we move on to palpation with the way that the checkoffs are set up. I know that his back is to you, but there's not too much back here I need to palpate. Here, rotate around sideways. He's got the video, so let's go this way.
Exactly.
Right. So palpation-wise, you're going to basically start at the occiput, or the base of the skull. Once you find that, start walking down the spine, along the spinous processes, all the way down to C7. Sometimes you can see it on folks. C7 and even T1 sometimes blend together and you can't tell if you're on 7 or if you're on T1. But go with the most prominent one and we'll call that vertebral prominence. Okay, so that's probably C7 right there. Okay. While I'm back here and I'm already on his posterior thorax, I'm going to go ahead and palpate over to some of the shoulder palpation points. So I'm actually going to kind of start with palpation before I do the shoulder motion because I'm already back here and I don't want to move the patient around any more than I have to. So I'm along the medial border of the scapula. I'll walk back up. I'm going to find the spine of the scapula. I know you guys can't see this right now. I apologize. Spine of the scapula through here, out onto the acromion. It's an official one for you guys. No, it's not. But while I'm here, I'm already out on the acromion. If I go to the chest, rotate you back around. We need you on the bath part, yeah. So I'll go ahead and do it on this side for you. Find the notch of the sternum. Come across to the sternoclavicular joint, basically where your clavicle is meeting the sternum. Walk along the clavicle out to the AC joint. I'm not used to doing this from behind, but we're doing it for you guys. If you find where the scapula and the clavicle come together, you can usually fall into a little bit of an indentation, kind of a little triangle right there. If you then just come anterior or towards the front of the shoulder, this right here is the AC joint. So sometimes it's hard to find on somebody who's muscular or even somebody who's obese. You might not be able to see. You're so... I'm the obese one. If you're not sure, you can press down on the clavicle and see if you can feel movement underneath your fingers. That'll help you find the AC joint. You're going to get them that for volunteer. You come down across the front of the shoulder further. This bony bump that's sensitive probably, that's the coracoid process. That's the attachment of your coracobrachialis muscle. But while I'm still in the front of the shoulder, you can work your way towards the bicipital groove. And if you're not sure if you're there, you can rotate the forearm back and forth. And sometimes you can feel it glide underneath your fingers. You'll feel a little soft bump. You should be able to feel a bony bump, your greater tubercle, as you rotate outward the groove and then the lesser tubercle. Right in the middle of that is the bicipital groove. Okay? And greater tuberosity and rotator cuff insertion is on the humeral head. So we're talking about below the soft spot where the bursa's at, but deeper down in here and even a little bit forward. That's greater tubercle right there and rotator cuff insertion. Let me just do a quick look at the checkup. I think I've got all of the shoulder palpation points. All right. So from a shoulder standpoint, now that I was behind him and did all that, let's go ahead and we'll do the motion. I just want you to imitate my motions. Go straight up ahead and overhead. That's shoulder flexion. Go straight out to the side and overhead. That's abduction. You can go ahead and bring them back down. And there's a couple different ways you can test active external rotation and internal rotation. Thank you. Active external and internal rotation, if you want to test them thoroughly, you can go ahead and do Apley's scratch test, which is basically I'm going to have you reach, let's say the right arm is the affected arm. I'm always comparing bilaterally. Go ahead and reach over to your opposite shoulder blade. Good. Come back around to the front to your opposite shoulder blade. And then go down around the back to your opposite shoulder blade. That's going to fully test internal and external rotation in all planes right there. Now, those were active motions right there. If we want to do resisted motions, bring one arm up in front. This is shoulder flexion. Push down, hold it strong. Good. Go ahead and bring it out to your side. I'm going to push down, don't let me. That's shoulder abduction. Bring your elbow down to your side. You're going to do resisted internal rotation, so pull towards your belly. Good. Keep your arm right there. I'm going to push against you, don't let me. That's resisted external rotation. Okay? So that's a way that you can go through the active range of motion as well as the resisted or strength testing. As we've gone through all that, I think I've hit all the landmarks. So we'll go ahead and move over to the special tests. You can actually kind of flow through these special tests really quickly when you guys do it because it's not like you're doing it specifically for diagnosis, but you're doing it for your checkoffs. If you go ahead and put your patient in this position right here, hold it right there. I'm going to rotate your arm up a little bit. Do you have any pain? Okay, so that's a negative Hawkins test. You can take them straight out into this position. Felt that nice clunk in your shoulder? That's just your labrum, don't worry about it. Hold your arm right there. So I put him in that position, so I didn't even have to explain to him what I wanted him to do. This is empty can test. I'm going to push down, don't let me. Okay, good. I'm going to go ahead and bring you in front. Keep your arm right there. This is a speeds test. Hold it right there. I'm just going to push down, don't let me. That's for biceps, long head of biceps. Okay. And then we can either have your patient reach across as far as possible, or you as the examiner can bring them across and do it passively. Is that causing you pain at all there? Okay. And when you do this, if they say that it causes pain, have them clarify where it hurts. Because it's a test for the AC joint. So you want to know, does it really make it hurt up here, or do you feel something stretching in the back of your shoulder when I put you in that motion, so that you know if it's a positive test or not? Okay. So shoulder, we're going to move on from the shoulder to the elbow. Basically, straighten them completely out in front of you. Bend them all the way up, touch your shoulders, back to normal. Bring your elbows down to your side. If you want to go ahead and do the pen thing, you can always start them here and rotate them each way. But what I usually do is I'll say go ahead and put both your palms all the way up so he's got full supination on both sides. Go ahead and turn them down, full pronation on both sides. So then we'll do resisted motion. We're only testing, I take that back, we are testing all four. Go ahead and pull up against me. That's resisted elbow flexion. Push down against me. That's resisted extension. And then to do pronation and supination, you basically just grab my hand like you're shaking my hand. what I'm going to do is I'm going to rotate my hand this way. I want you to rotate yours against me the opposite way. So this I'm trying to test. I'm basically testing resisted pronation. Now let's go the opposite direction. Good. That's resisted supination. So if you get in that handshake position, you can check both ways. It's a little bit easier there. Elbow, you guys don't have any specific test, which is good, but all of your palpation landmarks, try to show them to you guys. I usually will start on one side versus the other and try to hit all the medial structures before I go over and do the lateral structures. That way you can just do them all while you're there. Medial side, you've got medial epicondyle, that's that bony bump right here. The medial collateral ligament comes down from there into the proximal forearm a little bit. It's hard to really feel that distinctly, but you're just going to go distal to your medial epicondyle. If we go to the ulnar side, we've got lateral epicondyle right here. Lateral collateral ligament comes down. Radial head is kind of deeper down in here. And if you can't find it, what you can do is put your thumb over it and do a little bit of rotation. Remember that pronation and supination is going to take place on that radial head moving on the humerus and feel a little bit better there. And then just distal to the radial head would be where the annular ligament is. But I think at this point they're going to be able to palpate radial head and annular ligament at the same time since they're so close to one another. You've got tip of the bone, olecranon. I don't know if olecranon bursa would be on there, but it'd be on top of the olecranon. Let me make sure. I think we got everything there on the elbow, so we'll move on to wrist. Once again, I'm just going to have you imitate what I'm doing here. So wrist flexion, wrist extension, come back to normal. We'll go radial deviation, so go towards your thumbs. Perfect. Go ulnar deviation. Good. All right, so we've got flexion, extension, radial and ulnar deviation. And go to resisted on
That's a lot of
that.
things.
Yep. So go ahead and bend up. This is resisted flexion. Good. Turn your hand over and cock your wrist up. Resisted extension. Right there. All right.
Can you just do it in that same motion, or do you have to have them flip?
You can do it in the same plane if you wanted.
Okay.
Yeah, it's just habit.
Okay.
Thing. Yeah. Move on to bony landmarks. We've got distal radius through here. Ulnar, distal ulna and ulnar styloid right here. Thumb straight up in the air for me. He doesn't have, there it is. It doesn't jump out in terms of having the big indentation right there, but I can feel the tendons, so his anatomic snuff box is in this location. Okay. If we go to the palm side, over in the hypothenar eminence, this bony bump right here, that's the hook of the hamate. We go back towards the thumb. We've got the thumb CMC joint is underneath here, and if you need to move the thumb around a little bit and circumduct it just to find the base of that thumb, you can. And then if you go just a little proximal, kind of between that and where your anatomic snuff box was, you're going to be able to get to the trapezium, which is the bone that makes up the CMC joint with the thumb. I'll take a quick peek just to make sure. I think we got all the bony landmarks there that you guys have to cover. And then we go into special tests. The Tinel is basically finding that last crease on the wrist, going more midline, kind of right between your thenar and hypothenar eminences. And just let me know if it reproduces any kind of weird feelings at all or anything in your hand. And you can just see I'm not putting major force on it. It's more of an annoying tap than anything else. Anything weird going on there? All right, good. All right. If he said yes, you want him to clarify which fingers or what he's feeling, basically. Okay, so negative Tinel. Phalanx, I'm going to have you go ahead and put the backside of both of your hands together, best you can. Kind of take a glance at my watch or the clock. Let me know if you start feeling any kind of weird sensations at all, anywhere, if you have any pain, numbness, tingling, anything at all. In theory, you're supposed to hold this for a minimum of 30 seconds to a minute, but when you guys are testing and stuff, you just can verbalize that. You want to keep them in that position. You can relax. If you had any symptoms at all, you would document, at what point clockwise symptoms started. Move on to a Finkelstein maneuver, and I basically just have you wrap your thumb with all your fingers. Do it slow because it sometimes can't hurt, but I want you to go ahead and do any significant wrist pain at all there.
I can do it like,
Gotcha.
I don't know.
Yeah, so Finkelstein maneuver there.
Look, no
All right,
problem.
so moving on to the hand, we've got all kinds of
I don't know
motions
what's
we
going
can
on.
check here. basically with one hand is fine, but you'd always compare bilaterally. So anytime you're doing your checkoffs, check one side, but make sure you verbalize it. Go hand flexion, finger extension. Spread your fingers out real wide. That's abduction. Bring all your fingers back together. That's adduction. I'm going to go to the thumb right now and do thumb flexion. Good. Thumb extension. Thumb abduction. So you're pulling the thumb away from your hand, and then you're going to bring your thumb back to your hand. That's thumb abduction. Then we're going to do opposition, where you can go thumb to fingertips, and then you can go to the as far down as you can on that small finger till you get down towards the palm. Okay, good. All right. So we've done the motions of the fingers there. We then do resisted. We're going to do resisted finger flexion. I'm going to kind of grip your fingertips like this and hold against me. Okay, so that's a resisted finger flexion right there. Go ahead and spread your hand out real wide. I'm going to try to squeeze your fingers together. Don't let me. This is finger abduction. I'm going to put my fingers in between yours. Go ahead and squeeze my fingers with yours best you can. Okay, so that's resisted adduction there. Thumb motions, what do we have on there? Thumb flexion or just thumb opposition? I want to pull up by this afternoon in your textbooks and see how they recommend testing thumb opposition. If they've been doing pinch and trying to break pinch, or is it little finger pinch? All right, go thumb tip to little finger. I'm going to put my hand through there, and I'm going to try to break that. Don't let me. Yeah, so that's thumb opposition. I know it's hard to do, but that's thumb opposition. But I do want to check Bickley or Bates and just see what they've got in there so we're consistent. So as we get through that, we'll go to the palpation and we're good. So palpation-wise, we have metacarpals. So you want to push on the metacarpals. No, you're good.
Thank you.
So we got metacarpals. You're going to go through all of those. You don't have to go through it extensively. You're going to go to all of the phalanges. You've got proximal, middle, and distal phalanges. We've got MCP, or metacarpal phalangeal joints, PIPs, and DIPs. Okay? And anything else on there? Nope, that's it. All right. All right, so we're going to stop there on the kind of